I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Welcome to our webinar, Cardiovascular Conditions Close to One's Heart, presented in collaboration with Friends Health Connection. Cardiovascular disease is the leading cause of death in the United States. However, through diet and lifestyle changes, you can help reduce your risks. Advanced diagnostic tools and treatments have also helped improve outcomes for individuals with heart disease. During today's webinar, we will learn about risk factors for heart disease, how it can be prevented, heart attack, signs and symptoms, and the latest treatment options. Joining us today is Dr. Ranjita Sengupta, a board-certified cardiologist on staff at Robert Wood Johnson University Hospital, Somerset. Thank you for being here.
Thank you, Serena.
Before we begin, we will begin our webinar with about a 20-minute moderated conversation, and then we will open it up to questions and answers from our audience. So Dr. Sengupta, to get us started, please tell us a little about yourself. And you have such vast accomplishments. So maybe we could start off and share that with the audience.
Thank you, Serena, and thank you for having me here. Me and Serena, we go back a long time doing these community programs. And I'm a board-certified cardiologist at Robert Wood Johnson Somerset. And I am also a faculty now at Rutgers Robert Wood Med School. I am an invasive cardiologist. I perform cardiac caths with the novel radial approach. I am also board-certified in echocardiography, nuclear medicine, and cardiovascular disease.
Thank you. And that's just a snippet of it. So let's start off by explaining to the audience, what are the four main types of cardiovascular disease?
So if you split up the term cardiovascular disease, it's essentially cardio and vascular. So as a cardiologist, we are essentially thought of that we take care of the heart, but we take care of cardiovascular disease. So the four types of cardiovascular disease are, number one, the cardiac stuff or the heart stuff, where there is problems with the heart in terms of when patients come with chest pain, we call it angina, when patients present with heart attack or congestive heart failure, where fluid backs up in the lungs, or they present with arrhythmias. The second type of cardiovascular disease, where we are going more into the vascular part, is when patients present with a stroke or cerebral vascular disease, where they have limited blood supply to the brain, presenting with paralysis or difficulty in vision. The third type of cardiovascular disease, now we are going more into the vascular part, is what we call peripheral vascular disease, where patients present with problems in their circulation, where they have problems in the circulation in the legs, and they have pain when they're walking or climbing stairs. The fourth type of cardiovascular disease, again, more of the vascular part, is where patients have aortic disease. Aorta is one of the main blood vessels that comes out of the heart and supplies blood supply to the rest of the body. It's almost like the trunk of the tree, if you imagine, coming out of the heart and giving branches off to the main organs of the body. That's the aorta. Sometimes the aorta can be enlarged, or what we call dilated in medical terms, and what we describe it as called aortic aneurysm. And when an aneurysm happens, and if it reaches a certain size, it is at high risk of rupture, and that can be a life-threatening condition. And the recent guidelines are saying that patients should be also screened for aneurysm or an enlargement of the aorta in the belly too, because patients who are smokers, male, above 65, they are at high risk. So in very short, those are the different types of cardio and vascular disease.
Well, thank you. So as we mentioned earlier, heart disease is the leading killer of men and women, but in many cases, heart disease can be prevented. So what are the causes of heart disease, and how can people reduce the risks, both from the modifiable and non-modifiable risk factors?
You did your homework, Serena. I like that.
I had a good teacher, Dr. Sengupta.
That's great. So essentially, you said it the right way, modifiable and non-modifiable risk factors. In medicine, there is a big push or focus on what we call preventive medicine. And same thing in cardiology, because we know, just like we can prevent cancers, where we can pick up early stages of cancer and prevent it from growing to stage 4, same thing in cardiology, we can pick up cardiac disease at an early stage and prevent it from going into a heart attack or a stroke. So who are the patients who are at risk for developing a heart attack, developing a stroke? So essentially, you kind of alluded to that already. There are modifiable and non-modifiable risk factors. So modifiable risk factors, which are in our hands, that is things that we can do to prevent a heart attack or a stroke or a cardiovascular disease. And they are prevent smoking, okay? Take care of diabetes if you have it, take care of high blood pressure, exercise, essentially take care of yourself, okay? Then we have the non-modifiable risk factors, which is beyond your control, something that is genetic and something that you cannot control yourself. Age, people who are more than 65 in men and 55 in women, people who have family history of heart disease, early history of family premature heart disease in your siblings or your parents, and the male sex. Somehow the male sex is known to be predisposed to heart disease. These are the non-modifiable risk factors. But the modifiable risk factors are the ones where you need to see your doctor and take care of yourself so that you can prevent a heart disease and stroke.
Okay, so thank you. And so when we talk about risk factors, right, some of those risk factors can also be precursors for causing heart disease. But what ultimately causes? Is it arteriosclerosis? Is it hereditary?
So if you look at a little model, I hope all of you can see it. And this I often present to my patients when I tell them that what is heart disease and what is actually happening in the heart arteries that we say, patients present with a heart attack or a stroke. So if you see the first one, this is the inside of a blood vessel that is kind of opened up, and you see the cross section. It is completely clean, red, okay? There is no junk or anything inside it. If you see the second one, there's a little bit of yellow plaque, as we call it, is happening there. The third one is a little bit more, and the fourth one is OMG, all right? So this is where we are contemplating a stroke or a heart attack, all right? Normally, this kind of arteries we are seeing when we are born, okay? As we grow older, even as early as kids 12 years of age, we are seeing some little plaque formation. It's almost like the plaque that happens on our teeth, normal wear and tear. We go to a dental hygienist every 6 months and have it cleaned out, right? Unfortunately, I don't have a cardiac hygienist that I can go and clean out all that junk. So this is normal wear and tear that's happening, but along with your risk factors, if a patient has diabetes, if a patient has high blood pressure, a patient has high cholesterol, and they are not taking care of it, this can progress to this almost very, very quickly. In some cases, what happens, this inside of this little plaque that we are seeing and the covering that you see, which we call the fibrous cap of the lipid core or the cholesterol plaque here, under stressful situation, blood pressure shoots up, sugars are running haywire, that can rupture overnight, and that can lead to an acute heart attack where there is complete occlusion of blood supply here, leading to what we call acute heart attack or a stroke.
Okay, so heart attack and stroke, let's talk about that. For some people, that could be a little confusing. What is the difference between a heart attack and a stroke?
Right. So as we first started off by describing cardiovascular disease as cardio and vascular, so heart attack is heart, okay? And stroke is related to the brain. But the basic pathophysiology or the basic cause is the same. That is disruption in the blood supply. So when we are talking about a heart attack, it is a disruption of the blood supply to the blood vessels that are supplying the heart muscle, okay? So remember, when we contract our muscles, we need oxygen, right? And where do we get the oxygen from? From the blood. And the arteries that are supplying the heart muscles, if there is a blockage in there, no oxygen will be reaching the heart muscle. And what happens? If there's no oxygen, what happens? The muscle dies, all right? So that's a heart attack. When we talk of a heart attack, there is death of a heart muscle. So what we do in those kind of cases where patients are presenting with a heart attack, which is no blood flow to the muscle, no oxygen, so what do? We bring them to the cardiac cath lab immediately. We take a tiny needle. Serena is afraid I'm going to poke
Yeah,
her.
no,
Tiny needle like this, okay? And we put this needle in the wrist. I'm going to use it in this demonstration. This is the radial artery. We put the tiny needle in. It feels like a flu shot. Then through that, we pass this tiny wire. If you can see it, it's a very, very tiny wire, almost like an electrical wire that goes in. Serena is not feeling anything at all, okay? Then we pass this little, what we call sheath. It's like a bigger version of an IV that you get in the hospital, and goes in all the way into her wrist. It almost looks like this. You see this little end here. And through that, we pass what we call a cardiac catheter, which looks like this, again, a little bit like an electrical wire. We pass it through this, and it goes up all the way in the heart. And then we take pictures of the heart arteries, find out where the blockage is. And again, when we find the blockage, through the same sheath, we put in a catheter with a stent in and open up that blockage.
Am I awake for this?
Well, you're a little bit of a la-la land. Usually we do local anesthesia. We give you a little bit of Valium and Benadryl. Of course, patient comfort is first. We make sure our patients are comfortable. But I just wanted to say that it's such a simple procedure. So that's an acute heart attack. And when we do it for preventive purpose, when patients come in with stress tests, they have it abnormal, we do this procedure, and we open up the blockage before it progresses to a heart attack. Remember, heart attack equal to low blood supply, equal to low oxygen, equal to dead muscle. All right, so that's a heart attack. What is a stroke? The mechanism is similar, but the blood supply is to the brain. So something is causing the blood supply to the brain to be impaired. Okay, several causes. It could be same thing where patients who are diabetic, patients who have high blood pressure, high cholesterol, smokers. What happens is there could be a blockage that is developing over time in one of those vessels in the brain that causes the stroke. It could be, just as I described, remember that fibrous cap on the lipid core that could rupture one day due to acute stress, high blood pressure, smoking, inflammation. The lipid core ruptures, causes acute blockage in the blood supply to the brain. Sometimes patients, when they have an irregular rhythm called atrial fibrillation, they can have blood clots in the heart that can travel from the heart, remember, through the aorta, the trunk of the tree, to the branches going to the brain, and plug off a small vessel supplying a part of the brain. And that's when patients present with a stroke or a mini stroke, which is called TIA. Patients usually recover from a TIA fast. Strokes are more alarming in terms of involving bigger segments of the body. It also depends which blood vessel in the brain is being obscured or clotted off because of the low blood supply. So essentially, pathophysiology is the same, or the mechanism is the same, but different organs of the body are affected. So heart attack is heart, stroke is the brain, but the root cause of both are the same. That is blockage in the blood supply.
Very good. So what are some of the signs and symptoms of heart disease? So how does somebody recognize if they might have a problem?
So first of all, if you have risk factors, get yourself checked out, because when a patient is having symptoms, it is already a sign that something is happening. All right. So the symptoms that you should watch out for, I tell my patients these are the red flags. Okay. So chest pain. Sometimes it may not be a pain. It may be a pressure. Some people describe this as a person sitting on the chest. Some of my female patients describe that their bra is too tight. All right. Sometimes the pain could be on the left side, going down to your left arm, going up to your jaw and to your neck. Sometimes the pain can go from the middle of the chest through and through to the back, like almost to your scapula. And sometimes patients present with what we call congestive heart failure or shortness of breath because of the heart attack. Okay, so if you're severely short of breath, waking up at night, cannot breathe, cannot lie flat, those are some of the signs and symptoms that you should watch out for. There are some atypical signs and symptoms which patients should also be aware of. Indigestion. Sometimes we think indigestion is related to just bad food we ate, you're not digesting well. It could be a silent sign of a heart attack. So if you're having any symptoms, go see your doctor. God is an amazing scientist, and your body always gives you some signs that something's happening, and listen to your body.
Okay, very good. So You have mentioned women and heart disease, so let's talk about that for a second. How prevalent is heart disease among women, and how do women present differently than men?
So whenever I have like an interactive session, I often ask these questions to my audience that, what do you think is the highest cause of a killer in women? I'm going to ask you this since you're my only audience.
Oh, I'm going to say heart disease.
Good. So lot of people and a lot of women actually are not aware that the heart disease is one of the highest killers in our women population. 1 in 4 women will be affected by heart disease. It is that prevalent. You know, we always think of breast cancer. We are very cautious about going for our mammograms, you know, getting our colonoscopies. But sometimes we forget about heart, because when we think of heart, it's like, oh my God, you know, it's my heart, right? But the fact that I stress to my patients is it is preventable. You can prevent heart disease. You can prevent stroke. Just take care of yourself. So in women, as you see, the prevalence of heart disease is very, very high. And the signs and symptoms are also pretty different in women. They may have the classic signs and symptoms as we just discussed, you know, the chest pressure, the shoulder pain, the jaw pain, the neck pain. Some of the atypical symptoms that I see in my female population is fatigue, tiredness, you know, and sometimes we just attribute it, oh, you know, we're just running around, taking care of the family, taking care of the whole world, but no time to take care of myself, right? Mm-hmm. So excessive fatigue, dizziness, nausea, okay, like feel like throwing up, indigestion, and some patients having back pain, okay, like going across through the back. And then again, as I said, feels like the bra is too tight. Those are some of the atypical symptoms that you have to watch out for. Another thing you watch out for is like feeling like a cold sweat. Okay, not like when you're sitting outside in the sun and feeling hot and sweaty. It's like almost like a cold and clammy feeling. So those are the things that you should watch out for. And especially when you're exerting yourself, when you're doing your household chores, you know, going up and down the stairs, and suddenly you feel you're breaking out into a cold sweat. That is something your body is trying to tell you, okay? Don't push it away. Although we know we have to pick up our kids, we have to do the laundry, we have to cook, we have to take care of our husband, but always remember, you have to stay well so that you're around to take care of your loved ones.
Well, thank you. That's a great explanation. So, okay, so now somebody's presenting with some signs and symptoms. How do they ultimately diagnose heart disease?
So when we see patients in our office who are coming with chest pain, shortness of breath, palpitation, dizziness, number one, obviously the history is very, 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 very important. The history and what their risk factors are. So I will give you an example of one of my patients. He was a diabetic, high blood pressure, high cholesterol. He actually works in a pharmaceutical company. He actually owns it. And he just walked by to my office and said, you know, I've been having this indigestion symptoms. And I thought that maybe I haven't seen a cardiologist. I should have myself checked out. He walks in, okay, and his symptoms were classic. Whenever he walks, he's getting like a burning across the chest, okay? And so those are the patients that you know just by listening to the history and the risk factors that there is something going on that we need to act very, very fast. So he was taken to the cardiac cath lab immediately, ended up having 5 stents, and he was due to go for a cruise with 20 of his family members. And he made it to his cruise in 2 weeks.
Oh, wow.
And he's doing great. And so that's one category of patients where we act on immediately because just looking at the history and the risk factors. Okay. Then we see patients coming in who are relatively stable, family history of risk factors, family history of disease, they have risk factors. They may be having some symptoms intermittently, or some patients present to us even before they have symptoms for preventive measures. So what we do on them is we do stress tests where we put them on a treadmill, check EKG, check blood pressure, check the EKG for any changes, what we call ST depressions, which is the line on the EKG should be staying straight, instead it drops down. Those are signs that there will be something going in there. We also check an ultrasound of the heart, which is called an echocardiogram, which checks whether the heart is pumping good, the muscles are contracting well, which means they're getting good oxygen. Remember, low blood supply equal to low oxygen equal to dead muscles. If the muscles are contracting well and thickening well, it's a sign that the blood supply is good. If the muscles are weak, it's muscles are ballooning out, it's not coming in as much as it's supposed to. Indirect sign that this is going to a dead muscle because of low oxygen supply. When we do the echocardiogram, we also look at your heart valves, make sure that the valves are opening and closing properly, there's no leakage of the valves. And we look at other pressures inside the heart and stuff like that. We also look for plaque builds up in your carotid arteries, that is the vascular part of it. And in our diabetic patients, we also check for circulation in the legs to make sure that the circulation is okay. And remember, everything is preventable provided you come to your doctor on time.
Very good. So now we talked about diagnosis, we talked about EKG, we talked about echo, we talked about stress tests, just to name a few. So what about treatment? So once you diagnose, okay, and you have a diagnosis, somebody has heart disease, what are the treatment options?
Right, great question. And the treatment options for, I'm going to stick to the cardiac part because the other vascular part is a little bit different. I can allude to it a little bit, but I'm going to stick to the cardiac part more. So the treatment depends on what we are seeing. So when we are talking about thickening of the arteries or the plaque builds up, it depends on what we see on the test and what the patient's symptoms are. My pharmaceutical patient ended up having the stents because we knew that he was having significant blockages causing what we call anginal symptoms. And same thing, we took him to the cath lab, just like I demonstrated in
with my wrist.
We put in this little sheet, and then we passed the catheter in there, and through this catheter we do the stents. Right now, in some patients, when they have a severe blockage where we cannot put in stents, which is becoming rare and rare, that the procedures become so advanced, we are doing more and more. We can do stents on anybody right now. Or if it's a main vessel that we cannot do a stent, they end up having what we call coronary artery bypass grafting or open heart surgery, where we send them to a surgeon. The surgeon opens up the heart and basically does a bypass of the blocked artery. It's almost, if you think, if you are in traffic, the roads are blocked in traffic, but you have like an overpass that you can take to bypass the traffic. That's the concept. That's what is called a bypass surgery. So the surgeon, what he does is ignores the traffic here, takes an artery from the chest or a vein from the leg, and produces a bypass from the normal segment of the artery, creates like an overpass of the blocked segment, and goes to another normal segment of the artery. That's coronary artery bypass surgery. Sometimes patients are not amenable for surgery or stent, and we treat them with different kind of medications, and there has been different researches done. Big trial called the Courage trial came out that showed equal benefits for patients who has been maintained on medical therapy. But again, every patient is different. As doctors, we have to look at the patient as a whole, their risk factors, and decide what is the best treatment. A little bit about strokes and other vascular disease for patients who have had a stroke. If they present with an acute stroke in the hospital, if they are within a time frame, we can give them what we call clot busters to kind of dissolve the clot. If they have irregular heart rhythm, we try to bring them back into rhythm. We put them on medications and blood thinners to prevent them, the clots from going anywhere. And also we put them on different kinds of medications to prevent another stroke, a secondary event from happening. Regarding aortic aneurysm, used to be surgery in the past. Now we are doing stents in them too. And also for peripheral vascular disease, we're also doing stents and medications.
Oh, okay. So there are options out there for people.
Absolutely.
That's good to know. So in general, what can somebody do to maintain, overall good heart health?
Great question. Again, I cannot stress this enough. The first thing that you need to do is love yourself. Okay, because if you take care of yourself, remember, you will be around to take care of others. And as women, we sometimes tend to forget that. Okay, and how do you love yourself is by taking care of yourself, right? So you take care of your medical problems. If you have any risk factors, if you're not feeling right, go see a doctor. Okay, we don't bite. Nobody likes to see doctors, but we are there to help you. And unless you come to us, we can't help you. Get your blood pressure under control, get your diabetes under control, stop smoking. Smoking is like poisoning. You are literally killing yourself with every puff of smoke you're taking. And what happens is it affects each and every organ of the body from head to toe. The other thing is exercise. Very, 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 very important. American Heart Association recommends about 150 to 180 minutes a week at least. I stress on the word at least. If you can do more, even better. Exercise can be just walking. You don't need to, go to the gym and push heavy weights or run a jog. Start off by simple walking. If you can go to the gym, great. Try something that you like, all right? Pick up a dance lesson, pick up yoga, something that is outside of your daily physical activity. Be active at work, but the exercise part is separate from your activity at work. When you exercise, you release what is called endorphins. I call it the happy hormones. It is a stress reliever, helps in anxiety, helps in depression, creates your hormonal balance. You will sleep well. And you will see once you start exercising, after a while, if you don't exercise, your body will tell you, hey, get back to exercise. I don't feel well. We need those happy hormones. So very, 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 very important is exercise. Remember the magic number, 150 to 180 minutes a week at least. If you can do more, even better. So those are the basic things that you can do to take care of yourself. One other thing I also stress on is sleep. 7 hours of sleep, very, very important for good cardiovascular health. And of course, diet. You need to eat right. A lot of fruits, vegetables, proteins. A lot of studies are coming out shying away from animal-based protein nowadays. It's still not hit the guidelines yet, so we are not officially saying it, but more and more data are coming out that animal protein-based diet are not the best for cardiovascular patients. Again, not hit the guidelines, so be cautious with your red meat. Try more with plant-based protein. Poultry is also a little bit debatable at this point, but again, these are not guidelines-based. But again, sometimes it's hard to cut out everything completely. Everything in moderation is fine.
Great. Wow. Thank you for that huge and comprehensive overview. So because we just have a little bit of time left, I would like to open it up to questions from our audience at this time. If you do have a question for our doctor, please type in the chat feature. You can type your question right in, and we will be able to get that and answer it right away. While we're waiting for questions of our audience, I do have, getting back to exercise, the type of exercise. Yes. Should it be more anaerobic or aerobic, right. Versus, weight bearing?
Right. So what I tell my patients is, and based on, of course, research and studies done, is a combination of cardio and resistance training. Okay. So the cardio is when you are on the treadmill, when you're on the elliptical, when you're walking. You don't have to do heavy running or jogging. Whatever you can do up to your comfort level is good, right? And alternate it with some resistance training, especially upper body resistance training is very, very good for the heart, especially in women. You don't have to go crazy with weights. If you like doing weights, that's great. Do it with supervision. Make sure you're taking care of your back, because if you're going crazy with the higher weights, that can affect your spine. You can do simple resistance training with buying those bands. Mm-hmm. And when you're sitting and watching TV, just do some exercises with those bands. $5 at Walmart or Amazon, or even light dumbbells. Okay, so those resistance training, what it does is conditions the heart to the point that it slows down the relaxation phase and improves the blood flow to the heart muscles. So a combination is always what is recommended. Don't just do cardio every day, just alternate. Or if you hit the gym 3 times a week, I would say do like maybe half an hour of cardio, half an hour of resistance training. That's a good combination.
Okay. So you also talked about diet. So you talked about staying away from animal-based. But what role does sodium play in the diet as well as fats?
It's a great question. So sodium, one thing some of my patients ask, oh, I don't cook with salt. No, you need sodium a little bit, okay? So cooking with salt at home is perfect, okay? It's the sodium that hides in other stuff, okay? The bread, the yogurt. Read your labels, okay? Very confusing. So I tell my patients, keep a simple approach. Anything that you buy off the shelf, and you look at the labels, the label will say percentage, grams, milligrams, percent of your total calories, blah, 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 blah. Forget all that. Remember these 3 numbers, okay? The sodium, try to keep it less than 200 milligram per serving, 200 for sodium. Under the carbohydrates, don't look at the total, look at the sugar. Keep the sugar, try to keep it less than 10 grams per serving.
Okay.
And on the fat section, look at the saturated fat. Okay, don't look at the other fat. The saturated fat is the one that we don't want you to be consuming in higher amounts. Okay, keep that 0 to as low as possible. Okay, now that's a little bit of how you grocery shopping. And when you are cooking, also look at the sauces you're using. Things that are high in sodium are the soy sauce. So whatever sauces you're buying from the shelf, look at the sodium content, or use minimal, or make it fresh. Use fresh ginger, garlic, fresh herbs. I'm Indian. We use a lot of turmeric in our cooking. A lot of cardamom, cinnamon, cloves. Natural spices are always the best, and natural spices have a lot of antioxidants in them. They reduce inflammation and makes your cooking so much flavorful and healthy. Right? A little bit about saturated fats. More healthy fats, because you do need a little bit of fat in your diet. So this healthy fats from nuts, walnuts, pistachios, almonds, avocados, olive oil. Those are the healthy fats. So don't eliminate fats completely from your diet. Eat the healthy fats. The fats that we want you to avoid are the saturated fats. So not too much of the butter, the cheese. Those are the ones that you want you to avoid. Again, as I say, it's hard to completely cut it out in moderation. I also stress a little bit about our carb intake, which is very, very important for our female patients, because we cannot store extra carbohydrate in our body, because if we have too much of our bread, our rice, our pasta, what happens? It ultimately gets converted to fat and gets stored in our body. So in moderation, and try to eat more like a high fiber starch. If you're having some carbohydrates, use more like quinoa, which is high in protein, high in fiber. Whole grains, those are always the best. But refined flour, refined sugar, try to avoid.
That's great. Well, thank you. I don't see any other questions from our audience. So having said that, I know we're a little bit over on the time. So if there are no other questions, this will conclude our webinar for today. Thank you, Dr. Sengupta, and thank you everybody for joining us. Please remember that the opinions shared here today by our medical experts are not a substitute for medical advice from a physician. If you do need a physician, please call 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you so much. Happy Heart Month, and until our next webinar, have a great afternoon. Take care. Bye-bye.
Bye.